choices as an individual, as a collective. So, again, thank you so much for being a part of this, and warm welcome you. My name is Rosie Atunda, and inshallah today, so for the non-Muslims here, in case you hear me say inshallah, it's just saying by the special grace of God. So I will keep saying this over and over. And I would alternate us also at the Sakinah Medical Outreach. We do not discriminate. So it was Professor Nasir.
Oh, sorry about that. We lost your voice for some time.
Oh, my apologies.
Okay. So, A'udhu Billahi Minash Shaitanir Rajim. Bismillahirrahmanirrahim. On behalf of the Sakinah Medical Outreach and the directors of the outreach, I would like to welcome everybody to this call, which will be discussing a very, very important topic. As we are aware, we'll be discussing stroke today, and we have with us a seasoned professor in that regard, Professor Kolawole Wasiu Wahab, who has agreed to give us this diet this morning. We sincerely appreciate his accepting this offer to discuss a very important topic. We welcome everybody on this call, and we hope that we'll pay attention to detail, because once you listen to this message, it is important for us to disseminate it to our environment, because everybody cannot be on the same call. You will pass the message and know the importance of this topic that we're discussing today. We know stroke is the second leading cause of death worldwide. Meaning is one of the areas that everybody needs to pay attention. And it's also said that almost 50% of disability is caused by stroke. So you see why it is important that we take this as very important to everybody, all household. So this is very important. On behalf of the chairman of the Sakinah Medical Outreach, I again welcome you, and we are sure and very confident that the guest speaker of today will do very justice to this topic, and we hope the listener will also pay attention to those details. Thank you so much for coming.
Thank you so much, sir, for that very brave but actuating opening remarks. We definitely do miss our chairman here, but I'm hoping that he's able to join us before the end of today's session. He's always joining us. So if he's unable to join today, I can clearly understand that it is beyond his control. So thank you so much for the opening remarks and for bringing the good words of our able chairman. So right about now, we would go straight into the reason we're here, which Professor Nasir already gave a hint of why we're here. We're talking stroke. He gave some really staggering statistics regarding stroke. And if you look at Nigeria today, you would see that we have a good number of young people who are equally, getting stroke. And you begin to wonder, we used to think that stroke is for just elderly people. What is happening to young people as well getting a stroke these days? So really, thank you, sir, and we truly, truly appreciate it. Before I go on to introduce our guest speaker for today, is there anybody here who has benefited from our previous session?
Assalamu alaikum wa rahmatullahi wa barakatuh, everyone.
Alaikum assalam wa rahmatullahi wa
barakatuh. While we are waiting for Ajia Rafia to join us back, I think he's having network issue from her end. So I'm going to continue the session while he will later join us. We welcome our professor, Professor Kolawole Wasiu Wahab, to this wonderful session. So before I will start, I would like to run through the profile of our guest speakers. And through that profile, actually, you will know that the person here today to take us through this topic is a well-known and it is a luminary when it comes to talking about stroke. So let me quickly run through the profile of Professor Kolawole Wahab. Professor Kolawole Wasiu Wahab is a 1997 medicine and surgery graduate of University of Ilorin with postgraduate specialization in internal medicine, neurology, and public health. Professor Kolawole Wahab currently works as a professor of medicine at the University of Ilorin and doubles as an honorary consultant neurologist at the University of Ilorin Teaching Hospital, where he heads the premier stroke unit in Nigeria. After completing a neurology postgraduate residency training in Nigeria, he had further training in the United Kingdom at the University College London, Institute of Neurology, and the National Hospital for Neurology and Neurosurgery, Queen's Square, London, where he studied on Commonwealth scholarship. He was also a visiting fellow at the Miller School of Medicine, University of Miami, and Jackson Memorial Hospital, Miami, Florida, USA. Professor Abdul-Wahab Wasiu had a leadership training in California, USA in 2014, courtesy of the American Academy of Neurology Advocacy Leadership Award. Wa alaikum salam. Professor Wahab ranked among the 3% most cited scholars in Nigeria for the year 2025. He is a recipient of many awards, including the Islamic Development Bank Undergraduate Scholarship, International Brain Research, the Research Organization Travel Awards, Commonwealth Scholarship, and the American Academy of Neurology International Scholarship. He emerged the best researcher at the University of Ilorin in 2016 and was named an emerging leader by the World Heart Federation in 2018. In November 2024, he was presented with the prestigious African Stroke Organization or Suntoko Award for a significant contribution to stroke research in Africa. He works with his research team at the University of Ilorin Teaching Hospital in collaboration with researchers within the outside Nigeria to achieve the overarching goal of reducing the high and escalating burden of stroke in sub-Saharan Africa. Among other research grants, he is the African lead investigator in the ongoing international stroke clinical trial entitled Triple Therapy Prevention of Recurrent Intracerebral Disease. Event trial student was also the African.
Is it only me that I can't hear anything?
We can hear you. We can hear you. Please go ahead.
He is an elected fellow of American Academy of Neurology, American Neurological Association, and the African Institute of Public Health Practitioners, among other responsibilities. Professor Wahab is the current secretary of the Faculty of Internal Medicine, National Postgraduate Medical College of Nigeria. He previously served as the director of Center for Research Development and In-House Training Credit at the University of Ilorin and Secretary General of Nigeria Hypertension Society. On the international stage, he is a member of the Guidelines Writing Committee of World Stroke Organization and serves as a commissioner in the Lancet Neurology Commission on Stroke in low and middle income countries. His research outputs are chronicled in more than 200 publications in reputable outlets. He has made numerous scientific and in 5 speaker presentation nationally and internationally. Professor Wahab is happily married, and married is blessed with children, with 3 children. On this note, I welcome Professor Kolawole Wasiu Wahab to this session. Assalamu alaikum.
Wa alaikum salam. Thank you so much. I am back. Thank you for stepping in. I truly appreciate Mr. Cousin. Thank you so much. And Professor, thank you so much for joining us this morning. You know, while the manager was reading your profile, I almost said, Manager, I don't think we can live here today if you continue to read that profile, because for people like you, you've achieved so much, and we're very proud to be associated with you. And particularly because, you know, sometimes it's a little challenging to find role models, you know, Muslim role models who are doing incredible work. Thank you so much for the amazing work you do. And thank you so much for also giving yourself to the Ummah. May Allah continue to bless and uplift you. On that note, we'll move straight into the questions. We have a lot of them, but I'm hopeful that we're able to cover as many questions as possible. So let's start with the very basic question, because we don't want to assume that everybody knows what a stroke is. What exactly is a stroke, Professor?
All right. So thank you very much, and thank you so much for those kind words. Alhamdulillah Rabbil Alameen. So I'm very happy to be here, and I want to appreciate Sakinah Foundation for this invitation, for me to come and share with us what is happening in Nigeria, but not only in Nigeria, it's in Africa, and maybe globally, because unofficially Africa seems to be the capital, the global capital of stroke, and so this couldn't have come at a better time. So thank you very much for this opportunity to share. Now, straight to the question, what is a stroke? Now, to avoid technical jargons, let me use an illustration, and that illustration is to appreciate how God has done his work perfectly in creating us, and we are the most complex of God's creation, and he has made the brain the most complex of all the organs in the body. So he has created the brain, and he nourishes the brain through a network of pipes, which we call blood vessels. So these blood vessels are arteries and their veins. So what happens in a stroke is that one of the blood vessels, this is one of the pipes supplying the brain blood. One of those pipes could get blocked on the way to the brain. Okay, so if it gets blocked, you know that it's not going to supply blood to the brain. So that area of the brain that is dependent on the blood supplied by this pipe is going to die. Or that pipe can rupture on its way to the brain. So either way, whether it's blocked or the pipe ruptures, blood is not supplied to that part of the brain that is supposed to be nourished by that blood that is received. So that is what basically happens in the stroke. So we say that it occurs suddenly, and then the person has weakness on one side of the body or of the whole body. And if it lasts beyond a particular period of time, we call that a stroke. But beyond that, even if it lasts just about 1 hour, and then we do a confirmatory test, that is by doing brain imaging, we're able to see signs that there is blockage or there is rupture of a vessel inside the brain. Then we call it a stroke too. So in simple terms, when stroke occurs, blood supply to the brain is cut off, and the function performed by that part of the brain will be lost. So that is what stroke means. Thank you.
Thank you so much, Professor. And I really like the way you've been, re-emphasizing in simple terms, because one of the reasons that people, fall into pitfalls of some of these issues because they do not really understand. People explain to them in very complicated and complex words. And I really like that you've been saying in simple terms. Thank you so much for that. Professor, we know that stroke is now being described as a silent epidemic, or we could say a looming tsunami. Why do you think that is the case?
Well, it depends on the way you look at it. I don't think it's a silent epidemic. It's actually an epidemic now. It's not silent again. So if you call it a tsunami, yeah, it's going to be an appropriate word to describe that. It's a big problem now, because if you look back when the program was being introduced, I think someone was mentioning the fact that it used to be thought that it's a disease of the elderly. And that was actually what was reported some 50 years ago. Okay, because at that time, if you look at the number of people who are suffering from stroke, you look at out of 100,000 population then, hardly will you have maybe like 25 suffering from stroke. But the situation has changed now, because currently we have up to like 114 per 100,000 population suffering from stroke. That is like a quadruple effect. So it has quadrupled from what it used to be about 50 years ago to what we have now. And aside from that, if you look at the number of cases occurring per minute in Africa, you have 6 stroke cases occurring per minute. So meaning that for this 1 hour program, we would have had about 360 cases of stroke within this 1 hour period. So if by all standard, that is an epidemic. So that is why all hands have to be on deck. So that is looking at the cases. But in fact, when we look at what happens to them after they've suffered from stroke, majority of people may not even survive this. And up to 4 out of 10, if not properly taken care of, will die within 30 days. And at 3 months, about 8 out of 10, if they don't receive proper care, will die. So that is a big problem, and it requires urgent attention. Thank you.
Thank you, Prof. Earlier when I was doing the introduction, I mentioned the fact that people used to think that stroke was, would happen to elderly people. But currently, that is not the case. We're seeing a lot of young people also getting a stroke. And you've also alluded to that as well. Professor, why do you think it is happening to young people?
Okay, so we have increasing cases of stroke in young people, but not just in young people alone. In the general population, we have increasing cases of stroke. And the principal driver is the fact that we are urbanizing, we are westernizing. In any case, when you talk about risk factors for stroke, we divide these traditionally into 2. We talk about those ones that you can't do anything about. Those are the non-modifiable risk factors. And then we have the modifiable risk factors. And I'm going to start with the non-modifiable risk factors. So things like age. With increasing age, one is at higher risk of developing a stroke. Indeed, every decade added after the age of 55 years doubles the risk of developing an ischemic stroke. You look at gender, males are more prone to developing stroke compared to females. And then if I have a family history of stroke, it puts me at a higher risk of developing a stroke compared to someone without a family history of stroke. So these are some of the things that cannot be modified. So we call these ones non-modifiable risk factors, including race too, because Africans, Black Africans and Hispanics tend to have higher prevalence of stroke compared to the whites. Now, so I'm going to move on to the modifiable risk factors. And What this means is that if you are able to modify these risk factors, the chances of developing a stroke is going to be minimized. And that is where we can now have the dichotomy between the young and then the old developing a stroke. But like I said, it involves the two age groups. So hypertension is the major driver, because globally, hypertension is the dominant modifiable risk factor for stroke. And the case in Nigeria is even peculiar because we have a higher prevalence of hypertension. In the general population, if you take like 100 people, up to about 40 of them could have hypertension. And what is even more disturbing is that about half of these do not even know that they have hypertension. And of the half that even know that they have hypertension, they are not on treatment. So you now take those who are on treatment, and abysmal 7 to 8% are actually controlled. So you see why the problem is there. So very, very few people who are hypertensive are on treatment and are controlled. Okay, so hypertension is a dominant risk factor in both age groups, whether in the young or in the elderly. And then we have other modifiable risk factors like diabetes. Diabetes is when you have excess sugar in the blood that the body cannot regulate again. So that person is going to manifest with some other symptoms. So if someone has diabetes and it's undetected, or it's detected and the person is not taking care of it, then the person is at higher risk of developing a stroke. And then inside our body, we have blood, which I said nourishes the brain. That blood will have higher level of fat than what is expected. And indeed, you could have bad fat predominating, okay, being more in concentration compared to the protective one, which we call the good fat. So that could put the person at a high risk of developing a stroke. And then there are other things like smoking, smoking alcohol, and in the young age group, not only alcohol, people use other recreational drugs, okay, like smoking marijuana, okay, using cocaine and heroin. And we've had patients in a stroke unit at the University of Ilorin Teaching Hospital, young individuals developing stroke as a result of taking these psychoactive substances. So these are some of the things that are driving the increasing burden of stroke. Before our uncle, let me mention issue of alcohol consumption too, because people drink alcohol, and the first notion before that, if you take certain units of alcohol, it will protect against a heart attack or ischemic stroke, has been debunked. So no matter the quantity of alcohol you take, you are at a higher risk of developing both ischemic stroke, that is the one in which the pipe will be blocked, or hemorrhagic stroke, that is when the pipe ruptures before getting to the brain. So these are some of the drivers of the high prevalence of stroke in both age groups, whether in the young or in the elderly group.
Thank you so much, Professor, for being very gracious and for being a fantastic teacher. Because right now it feels like we're in a classroom and you're just explaining to us what stroke is, what we need to look out for, and the many more things you'll be sharing with us much later. I really like your approach, because even I, with no medical background, I'm following through, and I want to believe that others on this call are also following through as well. Thank you so much. Professor, you've talked about some of the major drivers of stroke. You've talked about hypertension, diabetes, and what have you. But I want to ask you, are there major warning signs and symptoms of a stroke? Beyond, this person has this medical condition or this medical history, are there things that, begins to happen to the body? And once we see them, we could easily say that, this person might be having a stroke.
All right, so thank you very much. So we have what we call the warning signs of stroke. And this includes things like sudden onset of weakness on one side of the body, You see someone developing sudden weakness on one side of the body, someone that you are having a conversation with, and all of a sudden is not able to use one side of the body. So that could be stroke. It could be sudden onset of speech abnormality. In actual fact, the person may not be able to talk at all, or the speech will become slurred. So you're speaking with someone and then the speech becomes slurred, then you should suspect a stroke. It could present with sudden blindness. It could present with sudden onset of severe headache or sudden loss of balance, what we call coordination. Okay, so these are some of the signs that you may see in someone who has suffered a stroke. Then we put this together in an acronym we call FAST. In actual fact, that has been modified. We call it B fast now. B represents balance. Okay, so the person loses coordination. So when he walks, he is not balanced. So that is the B there. E is for eye. And I've talked about sudden visual loss. Okay, so the person could become blind suddenly. Okay, so that is one of the signs of stroke. Okay, then F is facial droop. So you are talking to someone and all of a sudden he has deviation of the angle of the mouth to one side. Or you see that, oh, this person is not feeling fine. Suddenly you are discussing and then suddenly it becomes somehow. So you can ask the person to show you his teeth. So if you see deviation of the angle of the mouth to one side, it could be a sign of stroke. And then I've talked about weakness on one side of the body. So you could ask the person to lift the arms up. Okay, lift both arms up. And on the weak side, the person may not be able to lift the arm there. Or if he's able to do at all, that same side is going to drift down. Okay, so you could have that one, that is arm weakness. Okay, and speech. So you want to interact with the person. Oh, good morning. How are you today? And the person is just mumbling or is not able to talk to you. And this has occurred suddenly. Then you start to think of stroke. So the T there is time. That time is brain. You need to act fast. So when we detect any of these symptoms or signs in someone and they have developed suddenly, then we need to get the person to the hospital as fast as possible so that you could have medical attention. So these are some of the things we look out for in someone who has suffered from stroke. Thank you.
Thank you so much, Professor. And I really like the way you ended this particular question because it leads me on to the next question, which is about once you see any of the signs or symptoms, you should take the person to the hospital. But we also know that, in certain cases, people, perhaps out of ignorance or maybe because poverty, they identify this signs and symptoms, and rather than take the person to the hospital, they classify it as delay, like the village people have come for this person, and then they say, oh, let's take this person to the mosque or to the church, or maybe get this person and things like that. In that situation, what do you say to people who might be thinking in that direction? And how do you think they can better go about it, particularly when somebody collapses as a result of a stroke?
All right, so thank you once again. So if one detects signs and symptoms of stroke, the best to do is to take the person quickly to the hospital. But I appreciate the fact that we have people who may resist. In fact, when I give lectures on stroke, I usually give an instance of what happened. This is real life event. And I was at a program and someone developed a sudden weakness on one side of the body. And the next thing I said was that, oh, let's take this person to the hospital. But the person insisted that, oh, they had to reach out to the pastor first before getting to the hospital. So it took insistence before the person agreed. And of course, immediately we got to the hospital and ensured that we went straight to do imaging of the brain to confirm the stroke. and behold, the person bled massively into the brain. So you imagine what could have happened if that person went to the church and then is coming back, if at all, after several days to the hospital. The person may not even survive the stroke. That person is alive today. And this thing I'm talking about happened more than 10 years ago. So when stroke happens, the best place to go is the hospital. We have people who will say that, oh, this is stroke, you don't use injection. That is what we hear in local parlance. There is nothing like that. The best the best place to treat a case of stroke is in the hospital. And when the person gets to the hospital, he is going to be confirmed. I talked about whether the pipe is blocked or whether the pipe ruptures. Those are the two types of stroke. So we call the first one ischemic stroke, the second one hemorrhagic stroke. And management of each of these is different. That is why the person needs to get to the hospital, and then we need to have confirmation of the pathologic type, and then we'll be able to give specific treatment to the person. Thank you. Over.
Thank you so much, Professor. Before I go on to the next question, I can see that we have quite a good number of persons on the call. Thank you, everyone, for joining. If you just joined, this is the Sakinah Medical Outreach Quarterly Health Talk. Yearly, we have these conversations and they happen quarterly. This is the second for 2025. So that means for Q3 and Q4, we would also have, conversations like this. But let me also add that beyond this health talk that we do quite a number of amazing things, including helping people with surgeries, people we know that they cannot afford it. We have spent hundreds of millions of naira, trying to take people out of really bad medical conditions. So please, if you'd like to support the fantastic work that we do, I'm going to be sharing our account details with you very shortly. And you should also follow us on social media to, just be up to speed with the things that we're doing at Sakinah Medical Outreach. And you will love it, because beyond the information, we're also uplifting lives, we're saving communities, and we're bringing families together. So for Facebook, just search for Sakinah NGO. Sakinah spelled SAKINAH NGO. On Twitter, we're also the same. On Instagram, it's the same. So please do well to follow us, engage on our posts, and of course, tell as many people as possible to interact with us. We would like to have your support, either in cash or in kind. You can also check our website on sakinahoutreach.org to see all of the things we are doing. Thank you so much for your support very well in advance. And I will go back to our questions for our very distinguished and able professor. So, Professor, you've talked about the need to go to a hospital because, of course, there you would get the appropriate checks, and the doctors can very easily advise on what needs to happen urgently and subsequently. So let's talk about people who may not necessarily have access to the high-end hospitals. I'm talking about people who live in communities. What do you say to hospitals, particularly at the primary and secondary levels? Do you think they are truly prepared to handle stroke emergencies? If not, what is missing?
All right, so that is going to another realm entirely because this has to do with policy issues now. But the thing is, we have 3 levels of hospitals in Nigeria. We have the primary level, we have the secondary care level, and then we have the tertiary hospitals. So in the community, we have the primary care facilities. And under this, we have private facilities. But there are some private facilities that are offering secondary level of care. There are some hospitals that are even offering tertiary levels of care. So the fact that you have such in the community does not equate it to a primary care center. And indeed, some private hospitals are super specialized, are offering some of the services that could not be obtained in some public general hospitals or tertiary hospitals. So I need to put that in context. But the thing is, when you have someone with stroke presenting to a primary healthcare center, for instance, where there is no doctor, what is the role of the nurse there? What is the role of the community healthcare worker there, or the community health assistant there, in case there is no nurse? Okay, so they need to be able to recognize the signs of stroke. And once they are able to say that this is stroke, the best is to refer such patients. And I'm saying this because at the primary healthcare level, not only in Nigeria, in many parts of Africa, the services to adequately manage a case of stroke are lacking. Because for you to manage a case of stroke adequately, I've talked about doing certain investigations. Even the most basic of these investigations at the primary healthcare center, sometimes you may not be able to do. Not to now talk about complex investigations like doing brain imaging. So they are not available at primary healthcare facilities. So the best is to refer the patient to where the facilities are, so that the person will have confirmation of the pathologic type of stroke, and then adequate management could be instituted. The same thing will apply to secondary care facilities. There are some secondary care facilities, you have things like brain imaging, because at some centers you will have brain CT scan. So if you are lucky to be in a place like that, the best would be to confirm the type of stroke and offer the most basic of treatment to the person if you are not able to refer the patient immediately. And in case you are able to, you need to pass the buck and send to the facility where you have the manpower and you have the equipment to manage these cases. But having said that, even at the tertiary facilities, how many of our centers are adequately equipped? So that's the big elephant in the room. We know that at these centers, there are some that don't even have CT scanner. So if you have a patient with stroke there, how are you going to cope? And we have lack of manpower in some of these centers too. Okay, and this has been worsened by the Japa syndrome. When you have a case of stroke, the best is to be able to identify the signs at the primary care level. The person who is attending to the stroke patient should know his own limit. And if the person is presenting to a secondary care facility, he should know his limit. So that is the attending physician, and should be referred to a tertiary facility. And hopefully the person is going to be able to get the best of care at such tertiary facility. Now, in most cases of stroke, when the patient presents to the hospital, that is, you want to, or in all cases, you want to determine the pathologic type. So this is important because in some cases, you may be able to salvage the part of the brain that is not yet affected by using clot busters. This is not being readily done in most public hospitals in the country today. But we not doing that is a function of several factors, one of which is delay in presentation to the hospital. And that is why health education like this is very important, so that if someone detects any sign of stroke, he gets to the hospital early. Or if the primary care physician sees that, oh, this is stroke, he needs to refer the patient early. Because this clot buster we are talking about is time dependent. If the patient does not present early, then it may not be possible to use such clot buster in the person. For the one that is bleeding into the brain, then there are some interventions that are evidence-based now that you can do. But, you know, like I said, you need to confirm what you are dealing with before you give such evidence-based intervention. So I think I've been able to address this question, moving from the primary to the secondary and then to the tertiary care, and then looking at what could be done and what the drawbacks could be.
Certainly, Professor, you have done justice to that. Thank you so much. On this calls, we never can tell who is listening or who would listen to this much later. There's a possibility that we've got a policy maker on the call, and information like this can help them come up with small people-centered policies in the house. So thank you so much for doing justice to the question, even though you've acknowledged that it's a whole topic on its own, and hopefully we will get it better in Nigeria and of course in Africa as a whole. So Dr. Sorry, I'm calling you a doctor, but I believe you're a doctor as well, but I just want to stick calling you a professor. So let's talk more about response. Again, we've been talking for the most part, somebody who is about to get a stroke or how you can avoid getting a stroke. It's been more prevention, but we need to also acknowledge the fact that we have people who already have a stroke, and having a stroke is not the end of the world. So for stroke survivors, they often suffer long-term disability. How do you think that families and caregivers can support physical and emotional rehabilitation at home or in the community?
Right, thank you. So it's not all patients with stroke that will have a permanent disability, because we do have patients who suffer from stroke and they recover completely. The emotional aspect of it could be an issue, but in terms of physical functioning, we have quite a number of our patients who recover fully. But the thing is, you have about more than 50% that may have permanent disability, and that is where the issue is. So right from when the person is in the hospital, whether, because you can't predict who is going to have permanent disability by merely looking at the person. There are parameters that we look at before you can say that, oh, this is the likely outcome in this person. But right from the hospital, right from admission, we start with rehabilitation. So we start with physical rehabilitation, okay, so that the person can regain his functioning. And there are other things that we need to, that we usually bring in, like involving the social workers in the management of the patient. There are times when someone who was able just about 24 hours ago now suddenly become unable to use one side of the body. And such person could be distressed because it may even be that the person is not able to now communicate again. So that could be very distressing. So that is where support will come in from the family, from the other healthcare workers, so that they will not feel stigmatized, because there are people who have been abandoned just because of the fact that they suffered from stroke. And we have people who have lost their jobs just because they developed a stroke. And like I said, it's not every cases of stroke that will develop permanent disability. So we need to put all this in context when we are looking at the person who has suffered a stroke. So everybody has a role, right from the person himself who has suffered a stroke. The person needs to believe in himself or herself that I could get better and I could get well. I could return to normal functioning. Then to the family members, that yes, the fact that this person has suffered a stroke does not mean it's the end of the world. So we should be ready to support him, giving all types of support that are available, so that he will be able to continue to contribute his own quota to the society. And then to the other members of the society, when we see patients with disability, people who are stroke survivors, we should give them priority attention. and then to government facilities needs to be put in place so that we will have adequate rehabilitation, and then we'll be able to take care of the emotional aspect of the stroke too. So these are some of the things I think we can do with respect to managing the person who has suffered a stroke. But finally, stroke begets stroke. If someone has suffered a stroke, the likelihood of having another stroke is high. And that could be reduced if the person takes care of the primary reasons why he developed the first stroke. So if the person has been told that, oh, he has suffered a stroke because of hypertension and that he needs to take care of his blood pressure, he has to be taking the blood pressure medications as prescribed. And likewise for all the other modifiable risk factors. But sometimes the patient may not be able to do it, and that is where community like this or the government will come in because we need health insurance, and that is where Sakinah Foundation is doing very well. If we have patients who have suffered from stroke and they are not able to afford their medications, if we are able to help them to get their medications, is going to help them to control their modifiable risk factor so that they prevent a recurrence of the stroke. Thank you, Uba.
Thank you so much, Professor. You've been very gracious. Thank you so much. So right about now, we're going to be taking questions from our listeners. So either you would like to use the microphone or you prefer to send us a question in the chat. So I'm happy to take any of your questions. And because of limited time, we would only take a few questions. So please use the microphone to ask your question. But Doctor, we have a question here that we got from our online form. In fact, two questions. So this person is asking, what is partial stroke? Also, please advise if someone just woke up hurriedly and found out that he could not come out of bed, but had a turning eye and the whole room was turning at 360 degrees. What is the remedy to stop this episode? Though, after some time, the person was able to sit down and come out of bed. Please advise on the solution. The person does not have history of hypertension per se, but went through office stress before this fit. The age is 61, and this person is not a smoker nor a drunkard. That is how this person has sent this message. I hope the question is clear, Professor Star.
Yeah, it's very clear. So thank you very much for this. The first one on partial stroke. When you talk about partial stroke, maybe that refers to the degree of disability in the person. So disability in stroke could be mild, could be moderate, could be severe. So anybody who has mild to moderate disability could be referred to as having a partial stroke. So on the second one, someone waking up in the middle of the night, maybe not even in the middle of the night, now anytime, and lying down, and then suddenly the whole environment is spinning around. Okay, so it could be a sign of stroke. However, it may not be a sign of stroke. And I'm going to quickly explain this. It could be a sign of stroke because, like I've said, stroke could affect one side of the body or both sides of the body, or it could affect the organ of balance. So if it does affect the organ of balance, the person may have difficulty with balance. And occasionally, we do have patients who will have this spinning sensation, what we call vertigo. Okay, so that could be a manifestation with stroke. But by and large, the majority of cases of spinning around like that are caused by a problem inside the middle ear, where our organ of balance is located. So I will advise that if someone detects something like that, call on someone to assist you and get you to the hospital, because it's only when you get to the hospital that you'll be properly evaluated to see if there are other symptoms and signs that maybe you didn't even notice, and then you'll be properly assessed, and then a diagnosis will be made. But most of the time, the problem is in the middle ear, either due to an infection or due to what we call sediments inside the organ of balance. They're causing vertigo. Some of these are what we call benign paroxysmal positional vertigo. I wanted to avoid jargons, but in the simplest term, it's yeah, it's like you just suddenly become unsteady, and then the environment is spinning around. That could be because of affectation of the organ of balance inside the middle ear. But like I said, the best is for the person to get to the hospital.
Thank you so much, sir. Another question here. Is it true that constant sex and standing position of men can cause stroke?
It is not true. That is the short answer to the question.
So for the person who asked this question, that is a myth. It is not true. Thank you. So there's another question here regarding what is the Nigerian government doing to assist its citizens, especially those suffering from stroke. I mean, I had said initially when I saw this question that Prof is not the government, but I'll leave it to Prof to answer.
It's all right. Thank you very much. It's like you've answered the question for me because like when at a point I talked about policy issues. So the government may not be doing something directly with respect to stroke, and that is why the whole world is saying that we should put stroke on the front burner. Because if you look at the number of deaths we record from stroke every year, the government will need to know that they have to prioritize this. But it doesn't have to get to the point when people develop stroke. Okay, it will start from primary prevention. So universal health coverage is one, because I've talked about the major driver of stroke, that is hypertension, uncontrolled hypertension. And I talked about the fact that only about 7 to 8% of those who have hypertension are actually controlled to target. So you imagine what will happen to the rest, about 92%, what will happen to them. So, but if we have universal health coverage, and I know that, oh, I'm hypertensive, I go to my healthcare facility, they check my blood pressure and I require antihypertensive medication, they will give me, and I'm going to pay a token just like it obtains now, but with that is with public servants. So if I'm going to pay 10% of the cost of the medication, that's a significant leap. And in any case, that could be made free too. Okay, so that is one. Two, for those who have suffered from stroke, there are things that the government will need to put in place. But this is an ongoing discussion because I've talked about facilities at primary, secondary, and tertiary facilities. So the government will need to equip these hospitals so that they have all the necessary facilities to take care of those who have suffered from stroke in terms of investigation to determine the cause of the stroke, and in terms of facilities to adequately manage such patients. So these are the things that the government could do. So that's why I said it's a policy issue, because I'm not aware of what the government has done specifically. But in terms of budgetary allocation, maybe the government made budgetary allocation for some equipment, and then the hospital will find a way of managing all the other things in the hospital. So I hope I've been able to answer the question.
Yes, you have, Professor. Thank you so much for that. There's a question here on what can be done to ensure that the stroke survivors get grassroots follow-up care. I know that, Professor has spoken about this, but I just want to also add my voice that this is where foundations like the Sakinah Medical Outreach comes to play, and that's why I had to say earlier that please, you need to support us. We're doing great work, but we need resources. So if you're not following us, if you're not contributing yet, please ensure to do all of those things. But particular question, I don't know if our distinguished professor would like to add a word or two, but I know that you've touched on this multiple times earlier.
Yeah, absolutely. I think you've answered it too. You've added to what I said earlier on. All hands have to be on deck to support anybody who has suffered from stroke. Because you imagine someone who is the breadwinner of the family suddenly developing a stroke. Okay, so to that person, it's like a dream coming to an end if the person is not able to recover. And then what is going to happen to the family? A lot of support will be required from everyone, okay, in the society to be able to adequately take care of this person who has survived the stroke. And then what is going to happen to the family? What's going to happen to the children? So all hands will have to be on deck. And foundations like this could be helpful. And those who have suffered from stroke will form stroke survivors associations, which could be like a pressure group that will work with government to talk about some of the policies we have talked about this morning. Thank you.
Thank you so much, Prof. We are running out of time, but just for the sake of fairness, I'd like to take two persons on this call to also ask their questions. And I hope that is fine by you, Professor. My apologies was taking more. I'm so sorry. Thank you. So, Mr. Babatune, I can see that your hand is raised. Please unmute your microphone and ask your question. I would appreciate if you keep very succinct,
Yes,
Thank you.
thank you. Thank you for the opportunity. I want to appreciate the organizer and the presenter who has actually done a great job. Yeah, for the clarification and confirmations of causes of stroke, which I've heard from a non-professional. And my main aim of joining this program this morning is to hear confirmation. And I've gotten enough clarification and confirmation. So I say kudos to the organizer and the presenter. But there's a particular point that I heard from a medical nurse that persistent traveling could also resort to stroke in an individual. So, and I noticed that in the presentation, that is not mentioned. You mentioned other factors like hypertension, feeding style, like drinking, smoking, and all the rest of things. But I need clarification. Okay, you also mentioned somebody having sex while standing, so which I really appreciate. But I need a clarification on the issue of somebody traveling continuously that could resort to stroke. Thank you for the opportunity.
All right, so thank you very much. Issue of sex and stroke, we don't have any documentation on about standing, having sex, and having stroke. The other thing about traveling, again, there's no documentation. And in actual fact, maybe an anecdotal evidence now will be that if that is the case, then all the long distance drivers should have suffered stroke. You understand? Okay, so meaning that we don't really have any relationship between frequent traveling and stroke. And if it is road traveling, what about air travels? Then most of our politicians should have developed strokes too. So it is not true. The person who travels frequently could be harboring a modifiable risk factor, which he has not been taken care of. So it could be that this is an anecdote that the nurse is talking about, but in terms of documented evidence, we don't have written anywhere in the literature that frequent traveling could lead to stroke. Thank you.
Thank you, sir. God bless you.
Thank you, sir. Mr. Issa, your hand is also raised. Please go ahead and ask your question.
Thank you very much, Prof. May Allah increase you in knowledge. I listened to your lecture with an attitude of a student listening to the lecturer. So I enjoyed the presentation from the beginning to the end. Now I have just about 2 short questions. Now the first one is that, can stroke occur at birth? And if it can, what could be responsible for that? Then secondly, you made mention or advised the other time that people should be taken to the hospital. But as a layman, I've witnessed a situation whereby somebody collapsed, and instead of taking the person to the hospital, they started beating his chest. Could this have to do with stroke or something else? Thank you very much.
All right, so thank you very much. A stroke does not respect age, but like I said, the risk of having a stroke increases as one is advancing in age. So at birth, stroke will occur. Now, I talked about the pipe supplying blood to the brain. So that baby that has just been delivered could have blockage of the pipe supplying blood to the brain, or could have a rupture of the pipe supplying blood to his brain. So either of this way could lead to stroke in the person. But the issue is what could have led to this. So it could be something within the uterus before the baby came out, or that the baby has come out now and has acquired an infection, or maybe the person had a prolonged labor, and then there is reduced perfusion to the brain. And if there is reduced blood supply to the brain, what is going to happen? Oxygen supply to the brain is going to be reduced, and then that area of the brain could be at a risk of dying, so which we'll call a stroke. So that could be the plausible explanation for that. Now, the other one is about someone who collapses and then people beating the chest. That could be the appropriate response in such situation, because when someone collapses, you need to move close to the person and assess the person to be sure that the person is breathing and that the air is clear. If the person Mr. Babatunde, could you please mute? Okay, so if the person is not having a pulse, so that is where emergency responders will come in now, and these people could be in the community too. We don't have them yet, so but we have some people who are trained. So when you witness such a thing, you place your hand on the pulse of the person. If the person is not having a pulse, then they can start what we call cardiopulmonary resuscitation. So maybe that was what you saw as beating the chest of the person. So it could be to start the heart. And once you do that, the person could be revived. So, but if the person falls to the ground and the person is able to communicate, the only thing is that, is weak on one side of the body, and by virtue of that fact is not able to support himself to stand up. Such a person does not need beating his chest. The best approach to managing such a person will be to take him to the hospital. I hope I've been able to answer your question.
Thank you very much.
Yeah.
Thank you so much, Prof. Can I kindly crave your indulgence to take a final question from Mr. Muhammad? So, Mr. Muhammad, please unmute and ask your question very briefly. Thank you.
Assalamu alaikum to barakatuh. Thank you very much for an amazing lecture so far, sir. My question goes thus. Could severe damage to the head, maybe as a result of motor accident, which therefore cause hemorrhaging into the brain, could it be an agent for stroke?
Yeah, absolutely. So thank you so much. That could be one of the causes of stroke. But in that instance, it's going to be bleeding into the substance of the brain. So, but the majority of cases we're talking about here now as cases of stroke bleeding into the brain are the ones that are driven by hypertension. And we call those ones primary intracerebral hemorrhage. Okay, so the one you have talked about now will be those ones that are acquired secondarily, that is from a road traffic injury, for instance, to the head, and then the person bleeds into the brain. So the person could have weakness on one side of the body as a result of this. So it's one of the possible causes. Thank you.
Thank you very much, sir.
Thank you so much, Professor. We cannot thank you enough. I mean, Professor Sakinah was earlier regarding the style of not even saying you're a lecturer or saying you're a teacher, a boss teacher, because you explained to us in the simplest form, and many of us without medical backgrounds were able to grasp what you have said. As a result of the things you shared with us, I believe we will make who and form of truth. You can so a couple of days on me that means really nice thing. And like I said, it's not saying it's saying to Sakinah Medical Outreach for all of that. Like I said, the totally help provide
We can barely hear you, ma. We are not hearing you very well.
it's working. Can you hear me now? Oh, what? Can you hear me now?
Yes, it's kind of coming out better.
Okay, okay.
Walaikum assalam wa rahmatullahi wa barakatuh.
Hello, anybody?
We can still barely hear you. Okay.
Don't know if
Wabarakatuh. I think she's having network issue from end, and I think the next thing on the agenda to bring the program to the end for today's session and for the Q2 now is vote of thanks, which will be done by me. So on behalf of Sakinah Medical Outreach, we express our deepest gratitude for your presence, engagement in today's important session, which is centered on stroke. So a special thanks goes to our esteemed expert, Professor Wahab, for delivering such an enlightening, thought-provoking presentation. Your insights have not only deepened our understanding of stroke prevention, management, and system readiness, but have also challenged us to reflect on our collective responsibility to improve outcome. To all our attendees, we appreciate your time, contributions, and thoughtful questions. Your participation has made this dialogue truly meaningful. We hope today's session will inspire further action. So this is the second, we have this talk on quarterly basis, and this is for Q2. We are going to have another one for Q3 and Q4. We urge you to stay updated on our social media platforms, where you can get updated on when we are going to have another quarterly talk for Q3 and Q4. We look forward to your continued partnership. And don't forget, please, as the host has said earlier, our account number has been shared on the income messages. Please support the foundation so that we can continue doing the good thing that we are doing, continue putting smile on the faces of our community. Thank you, and may we all stay committed to safeguarding lives, saving lives, working for humanity. Thank you so much for attending this wonderful session. Thank you very much. We appreciate you.
Thank you.